Okay, look at the box first. Evaluation of the precocious puberty. Evaluation of the precocious puberty. If puberty comes girl age less than 8 and boys age less than 9, this is precocious puberty. Like, early secondary sexual development. If girls age less than 8 and boys age less than 9, that means early secondary sexual development. Then what we'll do, we will do the bone age evaluation. If it is it a normal bone age or is it advanced bone age? If it is advanced bone age, the next step is to do low basal LH. A uh, low basal LH, then GnRH stimulation test. Even if a low basal LH, if it is low, then we will do GnRH stimulation test. If it is still low, then it is peripheral precocious puberty. If it is high, like GnRH stimulation test, and there is high LH, then it is central precocious puberty. And if after advanced bone age, if there is high basal LH, that is central precocious puberty. In central precocious puberty, the causes are like idiopathic and CNS tumor, and peripheral is classic no, non-classic congenital adrenal hyperplasia, gonadal or adrenal tumor. If it is normal bone age, is it isolated breast development like premature thelarchy, or is it isolated pubic hair development, premature adrenarche? So this in this system there is the scenario of like early secondary sexual development, but so our next step is to do the bone age evaluation. Okay, the child has precocious puberty, the child has precocious puberty, the premature development of secondary sexual characteristics, the premature development of secondary sexual characteristics in girl age less than 8 and in boys age less than 9. Secondary sexual characteristics include breast tissue stimulated by estrogen as well as acne, adult type body odor, and pubic and axillary hair stimulated by androgen. By the history and examination, the patient this by the history and the examination, the patient in this vignette has signs of excess androgen, acne, body odor, axillary and pubic hair, but normal estrogen level. No evidence of breast development. Initial management typically include bone age evaluation, which is radiographic assessment of the hand and the wrist to assess skeletal maturation. Normal ossification of bone occurs, and in a predictable and age group sequence, the ossification can be affected by genetics and nutrition in addition to pathologic hormonal changes, excessive estrogen. For example, premature elevated estrogen in patients with precocious puberty can lead to premature epiphyseal fusion, in turn advanced bone age compared to the chronological age. Conversely, if a patient's bone age correlates with the chronological age, the clinical findings are often attributed to benign pubertal variant. Next, Okay, so this young boy has dyslipidemia despite maintaining healthy diet, despite maintaining healthy weight and lifestyle. Given his associated constitutional symptom weight gain, he should be tested for hypothyroidism with the serum TSH level. Hypothyroidism can decrease LDL clearance. Hypothyroidism can cause decreased LDL clearance due to decreased expression and activity of hepatic LDL receptor and is associated with elevated total cholesterol and LDL level and risk increased risk of coronary artery disease. It is also causes decreased activity of the lipoprotein lipase leads to hyperglycemia. In patients with hypothyroidism associated dyslipidemia, treatment with levothyroxine often improves the lipid profile, may obviate the need for specific lipid lowering therapy, especially in young, low risk patients if not already checked. TSH levels should also be considered prior to the initiation of statin medication, atorvastatin, because untreated hypothyroidism can increase risk of statin myopathy. Increased risk for statin myopathy. Okay. Why you choose hypoalbuminemia? No. Uh, uh, when you find a case with hypocalcemia, before choosing hypoalbuminemia, what you need to do? Corrected calcium. I have already done the corrected calcium. The corrected calcium tells it is 6.48. So it is still low. So decreased albumin is not the answer. I know that B is not the answer. and hypomagnesemia can cause hypocalcemia. I know that, so I picked that. Yes, corrected calcium is like mm, patient's calcium plus zero point 0.8 into 4 minus patient's albumin. Oh, patient plus, yes, patient calcium plus zero point 0.8 into means times 4 minus patient's albumin. So, what's your answer? Always in your practice life, when you find a patient with hypocalcemia, first do the uh, corrected calcium, because if corrected calcium is still low, if corrected calcium is low, then you are sure that it is not the answer. Minus patient's albumin 3.4, 3.4, yes, so zero point 0.6 into zero point 0.8, point, zero point 0.6, zero point 0.6 into zero point 0.8, point, yes. Okay, the approach of hypocalcemia, if you look at this chart, like look, if what they have said in the chart, the second part of the chart, if we know this chart, just we need to do the second part. Like if you find a case of low serum calcium, confirm with repeat measurement corrected serum calcium albumin, like what we have done, or measured ionized calcium, like corrected serum albumin or measure ionized calcium. If it is low, then uh, go for the magnesium level. If low magnesium level, is it due to drug or recent blood transfusion? If it is yes, then treat underlying cause and replete magnesium, like as this is the magnesium is the cause, so replete magnesium and IV calcium for severe symptoms. For they are talking about blood transfusion, like if you do a massive blood transfusion, you have to give calcium, like citrate actually binds with the calcium and thus causing low hypocalcemia. So repeated blood transfusion, like if you give massive blood transfusion like 3 or 4 bags within 2 to 3 hours, then this patient must need calcium. Okay, if low magnesium level, is it due to drug and recent blood transfusion, is no, then do measure serum PTH. If serum PTH is normal or high, if serum PT, is the serum PTH is normal or is it high? If it is normal or low PTH, if it is normal or low PTH, then so calcium is low, PTH is low, so hypoparathyroidism. So hypoparathyroidism, it may be due to surgery like parathyroidectomy, thyroidectomy, radical neck surgery, autoimmune like polyglandular autoimmune syndrome, infiltrative, metastatic cancer, Wilson disease, hemochromatosis, and genetic PTH gene, PTH gene or calcium sensing receptor gene mutation? Is it high? High due to like secondary cause, metabolic vitamin D deficiency CKD, inflammatory pancreatitis sepsis, oncology tumor lysis syndrome, and pseudo hypoparathyroidism. So this patient has symptomatic hypocalcemia associated with significant hypomagnesemia and hypophosphatemia. Hypomagnesemia is a very common in hospitalized alcoholics and can cause hypocalcemia by inducing resistance to parathyroid hormone as well as decreasing the PTH secretion. The cause of hypomagnesemia, the cause of hypomagnesemia in alcoholics is multifactorial and may include urinary loss, malnutrition, acute pancreatitis, diarrhea. These patient has additional feature malnutrition or malabsorption including anemia and mild hypoalbuminemia. Hypocalcemia due to hypomagnesemia is typically refractory to treatment with calcium unless magnesium is replaced as well. Although PTH levels increases rapidly after magnesium replacement, hypocalcemia takes longer to improve because PTH resistance persists despite improvement in magnesium level. Despite PTH deficiency, phosphorus levels are normal or low in magnesium deficiency. This is possibly due to intracellular phosphorus depletion. Got it? Sorry, which one? Yes, yes, no. The corrected calcium is for hypocalcemia only, not hyper. His bony, is there anything? Sorry. So it is the bone age. Where is the bone age? I have, yes, sorry, bone age is normal. Yes. So either it is premature thalarchy or premature adrenarchy, isn't it? Normal bone age. So you have to remember this box. So do you want me to read the explanation? Okay. Development of secondary sexual characteristics. Development of secondary sexual characteristics is premature, precocious in girl age less than 8 and boys age less than 9. Obese children are at high risk. Obese children are at high risk for precocious development, as adiposity can trigger excess insulin production, which then stimulates the adrenal glands to produce sex hormone. Isolated premature adrenarche is caused by early activation of adrenal androgen. Early activation of adrenal androgen. Typical manifestation include body odor, oily skin, acne, and pubic and axillary hair. However, estrogen and testosterone level remain normal. Therefore, there are no other signs of premature puberty, breast development, testicular enlargement, or virilization, that is clitoromegaly. Mildly elevated dihydroepiandrosterone sulfate present in children with premature adrenarche is not sufficient to attack the skeletal growth. Therefore, bone age is normal in these patients. Isolated premature adrenarche is generally benign but a risk factor for developing PCOS, type 2 diabetes mellitus, and metabolic syndrome, especially in obese patients. Okay, sodium is slightly low, isn't it? He has orthostasis, he has dry mouth, eosinophil high. These are the features of adrenal insufficiency. And he has metastatic lesion, one of the cause of primary adrenal insufficiency, metastatic infiltration. Okay, so this patient has evidence of primary adrenal insufficiency, likely due to metastatic breast cancer. The adrenal glands are a common site of metastatic cancer. The adrenal gland are the common site of metastatic cancer spread, especially for primary tumors of the lung, breast, kidney, skin, like melanoma, with extensive involvement of bilateral adrenal gland. With extensive involvement of bilateral adrenal gland, primary adrenal insufficiency can occur with manifestation reflecting adrenocortical destruction. Reduced aldosterone production causes reduced aldosterone production causes renal sodium and potassium retention, leading to hypovolemia, hypotension, orthostasis, hypotension, or orthostasis, hyperkalemia. The hypovolemia provides non-osmotic stimulus for ADH hormone secretion with consequent water retention and hyponatremia. Reduced cortisol production contributes to hypotension, causes constitutional symptoms, can trigger hypoglycemia, and may lead to eosinophilia by reducing eosinophil migration into the tissue. Because cortisol mainly inhibits the ADH secretion. The reduced cortisol level also contributes to hyponatremia. Although low morning cortisol level cause Although low morning cortisol level can suggest adrenal insufficiency, the diagnosis is made by co-syntropin stimulation testing. Co-syntropin is a synthetic form of ACTH. The absence of the expected increase in cortisol level following administration reflects adrenocortical destruction. The test is usually performed in the morning when cortisol The test is usually performed in the morning when cortisol response in healthy individuals are normally in the most pronounced. Measuring basal ACTH can help differentiate primary adrenal insufficiency from adrenal insufficiency due to hypothalamic pituitary deficiency, low basal ACTH. Okay, diabetic nephropathy is exceedingly common in patients with type 1 and type 2 diabetes mellitus, and is characterized by persistent albuminuria more than 30 milligram per gram and decreased GFR, elevated creatinine. Diabetes and diabetic nephropathy typically slowly progressive for years before clinical signs occur. The diagnosis is the diagnosis is usually made clinically when renal biopsy reserved for patients with an unclear presentation. In the absence of signs suggesting another etiology, gas in the urine, rapid progression of renal dysfunction, the diagnosis can be presumed the diagnosis can be presumed in patients who have persistent albuminuria and decreased GFR, prolonged and either of the following: prolonged history of diabetes, prolonged diabetic retinopathy. So prolonged history of diabetes, type 1 diabetes is typically clinically obvious at onset. Therefore, diabetic nephropathy may be assumed those with a decreased duration more than 5 years. In contrast, type 2 diabetes is often asymptomatic, so patients may have this disorder for years before the diagnosis, making the duration of the disease difficult to calculate. Proliferative diabetic retinopathy, both PDR, retinal neovascularization, and diabetic nephropathy are chronic microvascular complication of the diabetes due to persistent hyperglycemia. So the presence of proliferative diabetic retinopathy correlates with the diabetic kidney disease. Therefore, patients may have diagnosed with diabetic nephropathy if there is concomitant PDR, regardless of length of the time since the diagnosis. Next, high and potassium phosphorus may be low, 3 to 4.5 as far as we remember. Yes, calcium is high. Yes, clear. They haven't talked anything about lungs, so lungs are clear. Yes, it fits with the like lab. Like PTH is high, calcium is high, phosphorus is bit low, primary hyperparathyroidism, and he has abdominal pain like groans, bones, groans, stones. He does not have any sort of stones, but the dad it does not relate it, and he has like I think that men. Okay, okay, okay. This patient has type one. This patient has type 1 men, an autosomal dominant condition characterized by three primary tumors: parathyroid, three primary tumor, parathyroid adenoma or hyperplasia, parathyroid adenoma or hyperplasia, constipation, polyuria, possibly abdominal pain in the setting of high calcium suggestive of hypercalcemia, likely from primary hyperparathyroidism. Patients may have low or normal phosphorus. Primary hyperparathyroidism is common more than 90% patients with men 1. Usually occurs by age less than 40 and results from multiglandular parathyroid adenoma or parathyroid hyperplasia. And gastrointestinal pancreatic endocrine tumor gastrinoma, burning upper abdominal pain. This is only partially responsive to famotidine. This is only famotidine and antacid associated with blood occult GI bleeding concerning for Zollinger-Ellison syndrome characterized by severe and refractory peptic ulcer disease due to gastrin producing tumor gastrinoma. There may be pituitary tumor. Okay. Yes. Men type 1 PPP, pituitary, pancreas, and parathyroid. Okay, pituitary adenoma 10 to 20%, secretion of prolactin growth hormone, ACTH, non-functional producing tumor, and mass effect, headache, visual field defect. Primary hyperparathyroidism more than 90%, multiple parathyroid adenoma or parathyroid hyperplasia, and hypercalcemia, polyuria, kidney stones, and decreased bone density. And pancreatic gastrinoma, recurrent peptic ulcer, insulinoma, hypoglycemia, VIPomas, secretory diarrhea, hypokalemia, hypochlorhydria, and glucagonoma, weight loss, necrolytic migratory erythema, and hyperglycemia. HHS. Okay. First box, HHS, hyperosmolar hyperglycemic state. The patient's characteristics is type 2 diabetes mellitus and older age. Clinical symptoms: gradual hyperglycemic symptoms, polydipsia, altered mentation, coma, focal seizure, focal signs and seizure. Lab studies: glucose is more than 600 milligram per deciliter, frequently more than 1000, normal pH and bicarbonate, normal anion gap, negative or small serum ketone, and serum osmolarity more than 320 milliosmol per kg. In this management, aggressive hydration with normal saline, IV insulin, and potassium replacement. Even if potassium levels are normal, so if the potassium level is below 5.3, you have to give potassium. This patient has like 4 point something, 4.8. Okay. this older this older patient with type 2 diabetes mellitus, has HHS, hyperglycemic state triggered by hyperosmolar hyperglycemic state triggered by recent prednisolone use. In HHS, marked hyperglycemia, often more than 800 milligram per dl, and severely elevated plasma osmolarity more than 320 milliosmol per kg, causes dehydration, altered mental status, obtundation, lethargy, and focal neurological signs, dysarthria, seizures. Immediate management includes normal saline and insulin infusion and potassium repletion when potassium is less than 5.3. Although lab although lab potassium measurements is typically normal or slightly elevated, a total body potassium deficit 300 to 600 milliequivalent is present in most patients with HHS as well as a diabetic ketoacidosis. Potassium deficit is caused by glucose-induced osmotic diuretics, which leads to urinary potassium losses, and secondary hyperaldosteronism from volume contraction. And normal or slightly elevated potassium measurements are due to hyperosmolarity, which draws fluid, and potassium into the extracellular which draws fluid and potassium into the extracellular space, and insulin deficiency, which reduces the intracellular cellular uptake of potassium. Okay, so this is the main two cause. Okay, if potassium is not replenished, life-threatening hypokalemia can result after insulin and IV administration, both of which lowers plasma osmolarity and cause rapid potassium influx into the cell. Therefore, in both HHS and DK, patient should be frequently monitored and supplemented IV and supplemented intravenously when serum potassium level falls below 5.3. Okay. Looks like Cushing, hypertension, dark terminal here.
No, a glucose is high.
Okay. This patient has weight gain, psychiatric symptom. This patient has weight gain, psychiatric symptom, hirsutism, hypertension, and hypercalcemia. The constellation of finding is consistent with hypercortisolism, Cushing syndrome. This condition is most commonly due to exogenous administration. This condition is most commonly due to exogenous administration of the glucocorticoid, but can also be due to ACTH producing pituitary tumor, ACTH producing pituitary tumor, ectopic ACTH secretion, small cell lung cancer, and pituitary and primary adrenal disease. The initial step in the evaluation to confirm hypercortisolism with a late night salivary cortisol assay, 24-hour urinary free cortisol measurement, and or overnight low dose dexamethasone suppression test. These two of these first line tests should be abnormal to establish the diagnosis. If hypercortisolism is confirmed, ACTH level are measured to differentiate ACTH levels are measured to differentiate ACTH dependent Cushing disease, ectopic ACTH from ACTH independent adrenal adenoma causes. Okay, we need to do two tests from these three. Like you can do 24-hour urinary free cortisol, or you can do late night salivary cortisol is 4 a.m. salivary cortisol sample, like late night, like 3 a.m. 4 a.m. At that time cortisol level is in the peak, so you have to take the sample at night like 4 a.m. And low dose dexamethasone suppression test is like 1 milligram dexamethasone is given at night, and then at morning at 9 a.m. you have to measure the cortisol. Got it? In early morning cortisol is low always. uh, because you late night like 4 a.m. is peak level of the cortisol. That's why what can I say, and that's why we are told to study at very early morning, like before the Fajr prayer. At that time our cortisol level is at the peak, so our brain works more. Okay. Yes, early morning cortisol will be low or low normal in patients with primary adrenal insufficiency. However, there is considerable overlap in cortisol level in normal subjects and those with Cushing syndrome, and this test has low utility in the evaluation of hypercortisolism. Stress causes release of the cortisol. Yes. What's your point? uh, okay. In the primary adrenal insufficiency, our main in primary adrenal insufficiency, when we take the cortisol at morning, isn't it? Along with we have to take the ACTH also. Like um, for primary adrenal insufficiency to diagnose, you need cortisol as well as ACTH. But in Cushing syndrome, we are actually looking for the cortisol only. So for Cushing syndrome, we need a certain preparation for measuring this, for diagnosing this. I don't know you understand or not. Okay, you are okay. In Cushing syndrome, our main concern is what? Cortisol, isn't it? So when the cortisol is uh, when the cortisol is in the highest position, when the cortisol is in the highest position, so we have to take that sample. But in primary adrenal insufficiency, we know that cortisol level is low. So whenever you take, that doesn't matter. Like if you take in the early or if you take in the late night, our main concern is low cortisol. And in primary adrenal insufficiency or even the secondary adrenal insufficiency, the level will be low. If you take the night sample on that perspective, then you may misguide, because at that time the cortisol level is slightly higher. Got my point? So if you take sample at 4 a.m. and you thought that the cortisol level is normal, but if when you take the morning sample, you found that the cortisol level is low and along with the ACTH. That's why even if the cortisol level, when we are suspicious about the cortisol level, we need to do the ACTH too. Got it? Okay, I am sending you two reports. Wait, look at these reports. Wait, I am sending you. Then you will understand that what's the significance. It's from Bangladeshi lab, so you will understand. Okay, look at these two report. I have sent in the WhatsApp. Okay, first look at the cortisol. Cortisol is, there are two reports. The next one is in the next slide. Okay, look at the cortisol. Result is 11.1. And what you have, the reference value in the right hand side. The reference value shows like 6 a.m. to 10 a.m. morning. So you have to take the sample in between 6 to 10. And if you give the afternoon sample, you have to give it at the 5 p.m. So this is the way of giving cortisol. Okay. Look, cortisol level is normal, isn't it? Because morning and evening sample, cut mark is 17 and 19. So it is 11.1. It is normal, isn't it? And now look at the ACTH. Uh, what is the level of the ACTH? Yes, and look at the normal value. So you got, there is why they have done the ACTH, because your cortisol is misguiding you, but your ACTH is guiding you that what you have primary adrenal insufficiency. Got my point? That's why the morning and the evening, this type of word is uh, given in cortisol sampling. So if you don't do the ACTH, if you just if you have done the only cortisol level, then you have misguided. Next. Okay, several aspects of this patient's presentation suggest that refractory acute onset hypertension following surgery is due to adrenal crisis. Adrenal crisis, adrenal crisis can develop in the setting of acute stress or illness, surgery, in patients with adrenal insufficiency, chronic primary adrenal insufficiency, secondary adrenal insufficiency. These patients' history of SLE, which often require prednisolone therapy for flares, are evidence of hypercortisolism, central obesity, evidence of hypercortisolism, central obesity, purple striae, glucocorticoid-induced hyperglycemia, suggest chronic glucocorticoid therapy. Patients on chronic glucocorticoid therapy can develop hypothalamic pituitary adrenal axis suppression and secondary AI because this pituitary gland is unable to increase ACTH secretion when needed. Acute stress of these patients are at high risk of acute adrenal insufficiency. Adrenal crisis primarily presents with hypotension and shock. Hypoglycemia is usually present. Adrenal crisis is due to secondary adrenal insufficiency may present less dramatically than that due to primary adrenal insufficiency because only cortisol is deficient and angiotensin II mediated aldosterone production remains intact. Primary adrenal insufficiency involves loss of cortisol and aldosterone. However, cortisol does play an important role in maintaining vascular tone, and isolated cortisol deficiency can lead to hemodynamic collapse. The hypotension in adrenal crisis is often refractory. The hypotension of adrenal crisis is often refractory, and initial volume resuscitation and treatment require IV hydrocortisone or dexamethasone in addition to aggressive volume depletion. He is not, she is not growing enough. The patient's height is 2.5 standard. If height is less than third percentile, this is short stature. Like he is not growing. He is sorry. She is a short stature. Yes. So this patient's short stature defined as height more than second uh, height 2 or more than 2 standard deviation below the mean or less than second percentile for age. Given her high arch palate with dental malocclusion, short metacarpal bones, and a history of strabismus, and her findings are suggestive of Turner syndrome. Turner syndrome is caused by loss of one of the X chromosome. Classically, presence with the following short stature occurs in virtually all patients with SOX. Short stature homeobox gene is contained on the X chromosome. X chromosome. Presenting it is often presenting finding in the children without associated manifestation. Lymphedema in infancy. Dysmorphic feature include high arch palate and short fourth metacarpal broad chest and webbed neck. Gonadal insufficiency is due to replacement of ovarian follicles by connective tissue streak ovaries and becomes apparent in adolescent absent breast development, primary amenorrhea. And associated comorbidities include congenital heart defect and strabismus. Diagnosis of Turner syndrome is with a karyotype, and treatment is recombinant hormone when height falls less than fifth percentile to maximize linear growth potential. Estradiol therapy is initiated around age 11 to induce puberty and breast development. Estradiol is given at age 11 and reduce the risk of osteoporosis and associated cardiovascular complication. After menopause, progestin is typically added to mitigate the endometrial hyperplasia risk. Okay.
Which I could probably
Okay. So when there is high calcium, the next thing, sorry, I have said something wrong, like corrected albumin concentration or for both hypo and hypercalcemia.
okay.
And for hypocalcemia, we are doing the serum magnesium, or is it drugs, or is it another thing? But for hypercalcemia, we are going to PTH level. If PTH is high, or if PTH is high, normal, or elevated, if PTH is high, normal, or elevated, it is PTH dependent. Then causes are primary hyperparathyroidism, familial hypocalciuric hypercalcemia, and lithium. Familial hypocalciuric hypercalcemia and lithium. And if it is suppressed or PTH independent. If it is suppressed or PTH independent, then measure parathyroid hormone related peptide, 25 hydroxy vitamin D and 125 hydroxy vitamin D. Then the cause. Okay, causes of hypercalcemia can be categorized on the basis of parathyroid hormone level as PTH dependent or independent. PTH dependent hypercalcemia, PTH dependent hypercalcemia suppressed PTH is usually due to malignancy, vitamin D toxicity, or extra renal conversion of 25 hydroxy vitamin D to 125 hydroxy vitamin D in granulomatous disease, and that is sarcoidosis. And PTH dependent is elevated or inappropriately normal PTH is usually due to primary hyperparathyroidism. The patient has chronic asymptomatic hypercalcemia, most likely due to primary hyperparathyroidism. In normal individuals, elevated calcium suppress PTH secretion. However, parathyroid hormone-related peptide PTH secretion from anonymously functioning parathyroid adenoma or parathyroid hyperplasia is not suppressed. Most patients with parathyroid hormone-related peptide present with mild asymptomatic hypercalcemia, although potential clinical features may include nephrolithiasis, osteoporosis, nausea, constipation, and neuropsychiatric symptoms, stones, bones, abdominal moans, and psychiatric groans. In this patient, chronic asymptomatic hypercalcemia is and no family history of hypercalcemia, an elevated PTH level would be virtually diagnostic of parathyroid hormone related primary hyperparathyroidism. Okay.
46 year of man undergoes elective renal
This patient has a medical history of frequent headache, hypertension. In thyroid storm, like there may be fever, isn't it? Yes, and thyroid storm can come with this type of surgical scenario. Okay, okay. So, okay, in the light of patient's history of hypertension, frequent headache, his presentation with severe hypertension, pallor, sinus tachycardia, severe hypertension, pallor, sinus tachycardia is concerning for occult pheochromocytoma with a catecholamine surge due to anesthesia. Pheochromocytoma and paraganglionomas are pheochromocytoma and paraganglionomas are catecholamine producing tumor arising from chromaffin cell of the adrenal medulla or extraadrenal paraganglia, respectively. Hypertension in pheochromocytoma Okay, hypertension in pheochromocytoma can be intermittent or sustained. Paroxysms of severe hypertension can be paroxysms of severe hypertension can be precipitated by increase in intra-abdominal pressure, tremor palpation, positional changes, surgical procedure, and number of medications, particularly anesthetic agent. In addition to non-selective beta blocker can cause a state of unopposed alpha adrenergic stimulation leading to vasoconstriction and paradoxical hypertension. For these reasons, alpha blocker phenoxybenzaimine should be administered prior to beta blocker in the patient with pheochromocytoma. Got it?
like the background issue. Kind of the I know this is question because I noticed that in my country, main focus
There is weight gain. Uh, 10 kg weight gain over last year. She has been unable to lose weight despite, sorry, PCOS, maybe. Because there is show course here along the chin, like, yes. So, yes. Then BMI high. So, in PCOS, first give OCP. Weight gain, OCP, then maybe if he wants to uh, be pregnant, then latrozole. Okay. Okay, these patients irregular menses, hirsutism course here along chin, weight gain are consistent with polycystic ovarian syndrome. Patients with polycystic ovarian syndrome often have hyperandrogenism, diagnosed with either clinically hirsutism, severe acne, androgenic alopecia, or biochemically elevated testosterone level. Hyperandrogenism and the subsequent hyperandrogenism and the subsequent hyperandrogenism due to peripheral androgen conversion results in chronic anovulation. Anovulatory cycles causes irregular menses, decreased progesterone secretion, and uncontrolled endometrial proliferation from unopposed estrogen. When menstrual periods do occur, they are often associated with heavy bleeding, that may result in anemia. The first line therapy for menstrual regulation is a combination of weight loss and combined mm, estrogen progesterone oral contraceptives. Combined oral contraceptives contain progesterone to stimulate endometrial differentiation, limit contraceptive, reduce hirsutism by blocking the adrenal androgen secretion and increasing production of sex hormone binding globulin, which binds and decreases free testosterone. Next,
So if we do random simple experiments, what are the results we get? As see
he has like salt craving things, craving for foods like salty pretzels. Okay, I have. Okay, sorry. Uh, okay, I was seeing the question 16. Okay, this question I got the answer. Okay, I have as because I have heard whatever you said because lack of milk production like Sheehan's pituitary ischemic necrosis. Okay, so these patients a massive postpartum hemorrhage with subsequent lactational failure, hypertension, weight loss, concerning for Sheehan syndrome, ischemic necrosis of the pituitary gland. During pregnancy, the pituitary gland is physiologically enlarged and vulnerable to ischemia from hemorrhagic shock. This potentially life-threatening complication is characterized by anteropituitary dysfunction, deficiencies in multiple hormone synthesis, panhypopituitarism. Sheehan syndrome typically presents after delivery with failure of postpartum lactation due to prolactin deficiency and lactotrophic cell necrosis, secondary adrenal insufficiency, persistent hypotension, weight loss, lethargy is a common complication due to impaired ACT secretion. Amenorrhea and central hypothyroidism may occur. Management involves replacing the deficient hormone, but there is no effective treatment to restore lactation. Yes, Okay. In the evaluation of the depression, medical causes of depressed mood should always be considered. Although these patients fatigue, anorexia, memory impairment, lack of motivation, loss of libido can be attributed to MDD, major depressive disorder, salt craving, and reduced body hair are suggestive of primary adrenal insufficiency, also known as Addison's disease. Primary adrenal insufficiency results from autoimmune destruction of the bilateral adrenal cortex and presence with the following: mineralocorticoid deficiency causes renal salt wasting with hypertension, weight loss, hyponatremia, hyperkalemia, and dietary salt craving. Glucocorticoid deficiency leads to fatigue, anorexia, many psychiatric manifestations of adrenal insufficiency. It also causes hypotension, and androgen deficiency leads to loss of libido suppression, leads to loss of libido and suppression of the secondary sexual characteristics, reduced pubic hair. These effects are typically only seen in women because androgen production still occurs in testes in men. Because in patients with suspected adrenal insufficiency, salt craving and hyperpigmentation are specific for salt pigment and hyperpigmentation are specific for primary adrenal insufficiency. Help differentiate it from secondary adrenal insufficiency. The diagnosis of the primary adrenal insufficiency is made by stimulation of stimulating test co-syntropin, a synthetic ACTH, low production of cortisol following co-syntropin administration, low production of cortisol following co-syntropin administration is diagnostic of primary adrenal insufficiency. Got it? Okay, first go with the box. When there is hypoglycemia in normal response, when there is hypoglycemia, there is release of epinephrine. Epinephrine causes hepatic glucose production, and epinephrine causes hypoglycemia awareness and behavioral response. And epinephrine causes hepatic glucose production. Ultimately, there is correction of hypoglycemia. If the patient is diabetic, there is no epinephrine release, no hypoglycemia awareness, no hepatic glucose production, no behavioral modification, and there is risk of severe hypoglycemia. Patients with patients with type 1 patients with type 1 diabetes mellitus can develop hypoglycemia. Patients with type 1 diabetes mellitus develop hypoglycemia because exogenous insulin continues to be absorbed from the injection site despite falling glucose level. Those with long-standing diabetes more than 5 years often Also has alpha cell long-term diabetes more than 5 years has alpha cell failure, which can lead to decreased glucagon secretion and exacerbate hypoglycemia. Normally, hypoglycemia prompts a catecholamine surge. Hypoglycemia prompts a catecholamine surge, which increases the hepatic glucose production and triggers many of the characteristics neurogenic hypoglycemic symptoms. Arousal tremor. However, patients with long-standing diabetes often have blunted autonomic response to hypoglycemia with reduced hypoglycemic awareness. The blunted autonomic response is worse in patients who frequently have low circulating glucose level. Such recurrent or severe hypoglycemia reduces the glucose raising effects of epinephrine and suppress the symptoms related to the catecholamine surge. In turn, this increases the risk of progressively worse hypoglycemia episode, hypoglycemia associated autonomic failure. Okay, yes. If basal LH is high, then it is central precocious puberty, isn't it? And in precocious peripheral, there is congenital adrenal hyperpopulation, non-classic, and in central, what is karyotype analysis? In central, sorry, MRI of the brain, central brain, yes, central brain. Oof, I should think. I am thinking about the cause, like I forgot the idiopathic and the CNS tumor. Okay, so central precocious puberty. Central precocious puberty results from the premature activation of the hypothalamic pituitary gonadal axis in age less than 8 and in women age in boys less than 9. Early exposure to increased gonadal hormone results in breast development and testicular enlargement and axillary or pubic hair growth to a young age. High levels of androgen and estrogen also promotes increased bone formation and cartilage growth, which leads to early pubertal growth spurt, increased height velocity, and advanced bone age. However, estrogen stimulates the growth plate closure, so patients often have shorter than expected adult height. Central precocious puberty is distinguished from peripheral precocious puberty by an elevated LH and baseline due to hypothalamic secretion of GnRH. Often GnRH or following stimulation of the GnRH agonist. In contrast, elevated sex hormone in patients with peripheral precocious puberty suppresses LH via negative feedback. Okay, elevated sex hormone in patients with peripheral puberty suppress LH negative feedback. Although central precocious puberty is idiopathic, it can be the first manifestation of an intracranial process even in asymptomatic patients. Asymptomatic patients, as in this child, central nervous system can also cause precocious puberty, though endogenous hormone production, or by directly affecting the HPV axis. So patients with central precocious puberty require MRI of the brain to evaluate for hypothalamic or pituitary tumor. Okay, okay. Can we stop here? Okay, okay. What's our plan? Like, I think that our